Hey, this is Andy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. This is actually our first CEU episode of Season 4.
And what are we talking about?
We are going to be talking about vestibular rehab in concussions.
Yes, so this is, like Randy said, a CEU episode. So if you're interested in taking advantage of those CEUs, make sure you first thank Mass General Brigham, formerly known as Precision AT.
Yes, big thanks to them.
Who is our partner for CEUs. You can find all their information down in the show notes below, as well as a link to take your CEU assessment. And depending on when this airs or when you are listening to this episode, it might be free, it might be $1, it might be regularly priced. So make sure you check down below to see where we're at.
Yes. So in this episode, we're going to start with, as most education episodes tend to, we're going to review the anatomy of the vestibular system. And then we're going to examine the literature on the evaluation of the vestibulo-ocular system after a concussion. And then we'll examine the literature that's actually talking about the efficacy of using vestibular rehab after a concussion.
So back to our anatomy, but this is
you make it sound so forced.
No, it's good. It's just not things that you can see.
That is fair. It's really hard to see the vestibular system because it does live in the inner ear. So when you think of the vestibular system, you really kind of are going to look at two structures, and that's the semicircular canals and then the cochlea. In particular, we're going to focus on the semicircular canals, right? These are those like 3 half circles that kind of live in our inner ear, and they contain the hair cells that actually detect the velocity of our head motions, right? So when you move, the hair cells move a certain way, and then that sends a signal to the brain, hey, the head is moving this way.
Also, why some people are more sensitive to vestibular movements and some people are not.
Yes, and some people enjoy vestibular movements more than other people.
Mm-hmm.
Who could that be?
Some people are vestibular. I mean, it takes a special person to want to be upside down.
That's very true. I definitely do not want to be upside down. So I am not vestibular. So moving on from that semicircular canal and kind of going into where those canals kind of attach to the cochlea, there are two very important structures, and that's the utricle and the saccule. And again, this is kind of where that connection between the canals and the cochlea happen. The reason they're kind of noteworthy in this episode is because it does contain the otoliths. And in particular, that's the limestone crystals, also known as otoconia, that lie within a membrane that is also attached to hair cells. And the reason for these crystals is because it detects linear motion of the head. So not necessarily the rotation part, more kind of like how your body linearly is moving. So it detects that kind of motion within the head. So now your body's getting a full picture of rotations and linear movement as well.
So those crystals are attached to the hair cells?
They're attached into a membrane, and that membrane's attached to the hair cells. So it's almost like rocks and jello, and the jello is attached to the hair.
So the hair tells you how fast you're going, but the crystals tell you where you are in space?
Kind of. So yes, the hair cells are detecting the velocity, so how fast your head is moving. And then basically those otoliths, the crystals, are detecting basically a change in that velocity, right? So when your head starts to move fast, or like if the change in velocity happens within some kind of linear motion, the otoliths are going to pick it up. And as we talk more about like evaluating vestibular issues after concussion, you'll see why, like, say, like in certain types of vertigo, right, it's only a few seconds, because acceleration, your head's not accelerating the entire time. At a certain point, it's going to just hit a velocity, because acceleration is a change in velocity. So that's why like some symptoms of vertigo only last like a couple seconds or a minute or so, because those otoliths are now kind of settled. All right. So because they're only basically detecting a change in velocity, whereas the semicircular canals are picking up mostly the head movement.
Okay.
So essentially, all these structures contribute to our body understanding where our head is in space and how it's moving. And it can also help stabilize our vision during these dynamic activities because, as with sport, right, we're going to be doing a lot of moving and probably focusing on something. And if we couldn't really stabilize our vision, we'd be all over the place, and sports wouldn't be as entertaining to watch. So the reason how we're able to kind of stabilize our head to our body and stabilize our vision are basically based on 3 reflexes. The first reflex is the vestibulo-ocular reflex. So this maintains a stable vision during head movements. So, right, you can think about like, we'll go off of the theme of today, like football, right? A receiver's running, has to turn their head, look at the ball, keep running, focusing on the ball, right? That's kind of the idea there. The next reflex is the vestibulospinal reflex. This is essentially maintaining stability of the body in relation to the head. And then the vestibulo-ocular, which is stabilization of the head, basically using the neck musculature. So all 3 of those reflexes help kind of stabilize our head and help understand where our head is in relation to the entire body.
So essentially you have 1 for your vision, 1 for your body, and 1 for your head.
Correct. So during a concussive event, all these structures can be affected, leading to some of those common symptoms that we see with a concussion, right? You can see dizziness, you can see headache, neck pain.
Well, it makes sense because if you're talking about all the stability of these reflexes, then a concussion would alter the stability of those factors.
Yeah, absolutely. And also, to remember, like, the pathophysiology of a concussion is occurring in the brain. All these reflexes, all these nerves, all this stuff is going to the brain. So if we're having issues in that processing center, right, you can see where it's going to manifest for sure.
But not all concussions have a vestibular component.
That's true. So after someone sustains maybe a concussive impact or a concussive mechanism, right, there are some symptoms that will highlight a vestibular involvement and then also an ocular motor involvement as well. So some things to look out for with vestibular involvement is dizziness, having blurred or unstable vision. So like they're just not able to focus on something. Discomfort within busy environments. So say you're at the mall, right? There's a lot of people moving. There's a lot going on. And you just start to see a big increase in whatever symptoms that you have, right? That could be a sign of a vestibular issue. Symptoms of an ocular motor issue, again, are going to go into that blurred vision, right? You're not able to stabilize your eyes very well. Convergence insufficiency, things coming closer to you are going to get blurry a lot sooner or make you feel dizzy and stuff like that. You could see difficulty reading because reading involves eye movements, right? You're basically moving your eyes along the page. Headaches, difficulty tracking objects, right? You can't focus on those objects very well. Eye strain, dizziness, nausea. So really, if you see dizziness, you know for sure there's something going on vestibular-wise, vestibular-ocular motor. So that's for sure a big one. But essentially, any of those things that involve your eyes, you're probably looking at vestibular-ocular motor.
That makes sense.
Yes.
Those things kind of go together.
Yes, as we have noted, there is a reflex that they go hand in hand on how we function in a dynamic environment.
AKA sports.
AKA sports. So why do we even consider the vestibular system outside of all the important things we just said the anatomy and physiology is? The reason that why it's become very popular, and you can see it becoming more popular with like just take a look at the programming for the NATA symposium the past couple years. A lot of labs, a lot of presentations on using vestibular rehab with our concussion patients. And it's because these vestibular systems have been shown to lead to a longer recovery after concussion. So if they're complaining of dizziness or all like difficulty reading, eye strain, all that stuff, you can expect that, hey, this is probably going to take longer than someone who doesn't have those symptoms. Traditional concussion care, remember that old way of thinking was, hey, total rest, right? You didn't do anything, just put them in a dark room, get some rest and we'll be okay. So that traditional care really overlooked the vestibular system because it basically waited until 3 to 4 weeks. If like, hey, if these symptoms aren't getting better by that time, hey, let's kind of dive in and maybe address this.
I feel like also vestibular rehab is not something that we are like is one of our easy go-tos.
Yes.
So I feel like it could also be overlooked even if you know about it, because who's going to be like, oh, I know how to do vestibular rehab. Let's give you some vestibular exercises. It's not something that we focus on in school or in continuing education as much. I know it's getting bigger, but...
Yeah, and absolutely. And that's why there are more courses now and more topics on it so that we can become comfortable with it and familiar and be able to identify. But again, it goes back to that initial thought of how we treated concussions, right? If, hey, we just need to rest, why am I going to think, oh, we need to do this, this, and this too? Until, oh, well, it should have been cleared up by now. Now we need to refer, which is what we do. If there's something that's not improving, we refer. Mm-hmm. So I again, definitely can see why early concussion care, that wasn't a big topic, but, now that we're evolving and learning more about it, there's definitely some more stuff to do, just like how now we do light exercise with concussions. I mean, that's been a big step too.
Yeah, all the subconcussive research.
Yes.
And how you can start activity as long as it's not bothering their symptoms.
Yes.
That's a huge advancement of just not having to tell someone, no, you can't do anything. You have to sit in a dark room.
Yes, exactly. And, that ties right into what we're talking about with vestibular rehab. So when we're evaluating just if we're even looking at something that might have vestibular issues, there are some really high-tech options that are really cool and definitely not something that we're really taught as ATs. This is definitely something that's more like geared towards your specialist. Hey, if I'm referring someone, they probably have all the fancy toys that like look at how eyes are moving and all this stuff, and really cool. But they're also more like field friendly vestibular test. And in particular, we're going to talk about the VOMS and then the King-Devick as well. So for the VOMS, this is the vestibular-ocular movement screen. It's basically broken down into 8 movements, and that includes smooth pursuits. So there's a horizontal component and a vertical component. This is basically just, hey, they track your finger. Saccades, again, horizontal and vertical. So basically you have 2 fingers up, and they're bouncing from one finger to the other while keeping their head still. So it's just an eye movement. Then there's the actual vestibular ocular reflex. Again, there's a horizontal and a vertical component, and that's eyes are focusing on like your finger, and then their head's moving either side to side or up and down. And then there's the convergence, so how close an object gets to them before it gets blurry. And then visual motion sensitivity, so they're focusing on, like, say their thumb, and then they rotate around. So they're focusing on the thumb while the environment around them is moving.
And this is also why concussion is so importantly of multimodal ways of testing, because like we said before, concussion doesn't always have these specific vestibular components. So even though VOMS is a really great way to determine if someone does have vestibular things, there are not every concussion will light up on VOMS.
Yes, absolutely. So that's why it is important to have, like you said, that multimodal. The literature behind VOMS is pretty good. There's a lot of good support that it's able to identify those adults and pediatric athletes that may be having a concussion. It can do pretty good at identifying it. How you score it essentially is you're looking for a change in symptoms. In a perfect world, you could actually baseline VOMS, and then you basically are looking to change from their baseline. But that's a lot to do. I know it's already tough to get some teams in to just get their like neurocognitive testing done through like the different like sway and impact and stuff like that. So essentially you're just looking for that change in symptom, and how they scored it is really any change of a score of like 1 on a symptom, because you're supposed to ask them on a scale of 1 to 10, how does that make your dizziness feel, your headache, or just feeling foggy, right? Those are the 3 symptoms that they'll kind of go over as you go through the VOMS. And basically, if it changes at all, they're probably at a higher chance that, yeah, you probably have a concussion.
I mean, any positive VOMS that I've had, you can also visually see.
Yes.
Like,
yes.
you can see that they are unable to complete the task.
Yes, and that's the nice thing with the VOMS is it's not such a subjective thing that you're trying to get off the patient, like how they feel. It could be also somewhat objective that you're looking and, man, if their eyes are all over the place while they're doing these tasks, like, hey, man, this doesn't look good.
This is also something that I like to add to my concussion testing kit, I guess you could say, because even if it's something not vestibular, it gives the kid a feeling like I'm actually testing them. And yeah, I mean, I am actually testing them, but, you know, just asking questions, they can say no, 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 no,
yes.
no. Whereas, like, if you actually do a test with them that they can't fake, it makes them feel like just one more thing that, oh, that, like, this is actually something that, you know, it gives them another opportunity to actually maybe change their subjective answers.
Oh, I was going to say too, yeah, along those lines is it really gives a real situation that, like, yeah, like in the heat of the moment, it's probably easy to be like, oh no, I feel fine. Whereas you do this and you're like, dude, I can't even.
Oh, actually, I can't see my thumb.
Every time I look at your fingers, man, I can't even stay upright. And how am I going to catch a ball? How am I going to run? Right? So it does kind of make that a little more real to the patient that, like, oh man, something's wrong. I don't like this. But yeah, really any change of just basically a 1 point within that system score basically could indicate a concussion. And in particular, they found the vertical saccades and the horizontal vestibulo-ocular reflex components to be very sensitive too.
I have a really hard time to remember the names.
I do it so much that, like, I don't know, it's become second nature.
Yeah, I just mix them up. I have to look them up every time I do it.
Yeah, I mean, that's how it started for me when I'd write in my notes and be like, wait, which one? And I'd run it through my head. I'm like, oh, yeah, that one. So I get that.
VOMS, if you look up VOMS on the internet, there's like a PDF that has like pictures of people sitting and doing the test. So
yeah, for sure.
Really helpful.
The next one is the King-Devick. I feel like this was popular like when it first came out like a few years ago. I remember like it was like groundbreaking. Like, and that was right around the times I think people were talking about VOMS too. So it came out in an exciting time.
I feel like everyone's heard of it, but because it's expensive, no one actually uses it.
I was going to say,
so I don't know that I know it in theory.
Yeah, I was going to say clinically, I've never seen it done.
Right.
And I've heard of it. And I remember, again, it came out when, again, that big push on looking at vestibular and ocular motor for concussion. And, you know, it has a lot of good information behind it, and the literature behind it is supportive of it. So if you're not familiar with the King-Devick at this point, it essentially was a series of cards with numbers, and those numbers were basically in a pattern. And then the athlete would kind of read the numbers based on the pattern that they were supposed to. So the idea is, right, they're moving their eyes as they're doing it. So it's an ocular motor. It was done for time, so they were timed into it. I think now, like, it's digital. Like, I think you can do it on like an iPad and stuff, and like the computer keeps time for you. So I think that's the change. My thinking of it was just the little old school was the series of cards. But the literature is definitely in support of the King-Devick. So if you've already purchased it or like, hey, you're thinking about it, hey, it is a good system to go with. The sensitivity for it was 77%. Specificity was 82%. Basically, if any special test had that high of a percentage on sensitivity and specificity, we'd be using it every day. So you could feel pretty comfortable that, hey, this is a good thing. My money has been well spent. But again, the drawback of the King-Devick is it does cost money, right? You're going to have to put some financial backing into it. And from what I remember as the limitation was there was a possibility of a learning effect because there was only so many cards that they had.
Right.
So eventually the athlete could learn the cards. So that was kind of a risk. Now that it's kind of a digital, I think that might have been corrected. But unsure because I'm not familiar with the system, and I didn't necessarily want to dive into looking strictly at King-Devick research.
Right.
I wanted a little more just kind of a general, hey, here's how we evaluate vestibular issues. And then, of course, anytime we have an athlete that is having vestibular complaints, right, we do want to kind of evaluate that positional vertigo, the BPPV, benign paroxysmal positional vertigo.
Mm-hmm.
I believe I got that right.
Yeah, I had to moderate.
Yes, you did.
PPV at NATA, and I was like,
forgot
why
about
did
that.
I pick this one that's like literally the hardest to say, and I have to stand in front of people and say these, not just BPPV, but also say the entire
The full thing,
out.
yeah. Right,
I was regretting that.
That was you. Yeah, that was tough.
And it was like, luckily it was at 7:30 a.m.
I was gonna say it wasn't.
No one's gonna.
But that's
but
also,
it was full. It was pretty.
Well, that's the worst part too. It was in the morning, so you really had to lock in early.
I had to be on it.
Yeah, so we do want to rule that out. And remember, with this positional vertigo, the idea is we're looking at that otoconia, right, and those otoliths. So it's going to be changes of position that all of a sudden they get really dizzy. And the dizziness doesn't last very long. It's going to be a few seconds, maybe a minute or so, and then they feel fine, right? Those are kind of like those key, like, ooh, we might be looking at a kind of a positional vertigo kind of deal, right? Mm-hmm. Anything where they have a long-term kind of dizziness, that might be a different kind of vertigo. But one of the things that, again, it's become very popular is that position vertigo. And there's different ways that you can test it. And there's different ways to correct it. There's different maneuvers. Again, NATA has done a really great job with those labs and, getting us comfortable in doing that. So I definitely look into that as well. So we've evaluated. We don't like what we're seeing. We think vestibular's the problem. What am I going to do?
I ask my students that all the time. What are we going to do?
What are we going to do? And let me guess, they give you that look of, something.
No, actually, my students are very good.
Good job.
Yeah.
We like that. So when vestibular rehab is designed, it's going to focus on basically two categories, right? There's the idea of adaptation. And essentially, this is the body adjusting how much magnitude of a vestibulo-ocular reflex it does. So basically, when you have like a concussive event, the vestibulo-ocular reflex is all over the place. So your body might be trying to overcorrect and do too much, or maybe it's not correcting enough, and that's why you're having these issues, right? So basically, adaptation is basically your body just kind of recalibrating itself. Like, oh, hey, I'm not adjusting correctly. I need to fix this. I don't know why I did the whoa with that. But the next category would be kind of habituation. And essentially the idea of habituation is just the continued exposure of a symptom-provoking position or maybe a movement will lead to a symptom decrease over time. When I've seen vestibular rehab applied, I feel like I've noticed it's more geared towards that habituation that, hey, we're going to expose them to these exercises up to that area of, hey, like, I'm kind of getting symptoms, like maybe a change in symptoms of like a 1 or a 2, and then that's where we stop. I feel like that's been more common than I think like an adaptation kind of thing. I feel like habituation is more of a thing that we can kind of gauge and like utilize. So within the literature itself, there is a lot of support for vestibular rehabilitation in conjunction with other treatments that we'll do for concussion rehabilitation. The interesting thing is it has been shown that it could lead to a quicker resolution of symptoms and even a quicker return to play. Obviously, this is more particular seen in patients with abnormal vestibular function post-concussion. So if you have someone who's just having headaches and their VOMS is fantastic and you do a vestibular rehab, you may not see that much of a like improvement compared to maybe doing other things. So keep that in mind, right? It's not just a cookie cutter, one size fits all. Yeah, everyone's getting vestibular rehab now.
Well, I feel like with the online methods of like impact or sway or like some other concussion based testing, I feel like it really breaks down for you what the tests that they do mean.
Yes.
And so then you can figure out like, oh, is it a reaction time deficit, or is there a deficit in the balance or whatever? So then you can really sit down and be like, okay, well, they need to work on their balance, or like they still have a deficit in this, or they've returned this, so we don't need to focus on inspection time as much, for example. So then you can, okay, if they need some balance, okay, we can incorporate some balance exercises. If they need some reaction time, okay, we can incorporate some reaction exercises.
Yeah, absolutely, for sure. And then also remember that connection between the vestibular system and cervical neck musculature, right? So if they're having neck pain, right, maybe that is kind of something with the vestibular system, or, you know, something goes hand in hand. Or, hey, they're having headaches, but also the dizziness. Hey, don't forget the neck as well, right? The tension from there could be causing the headaches. And also the dysfunction at the neck could be helping or could be contributing to the dizziness as well. So definitely don't forget that mobilization. Well, first evaluation of the neck and making sure there's no deficits there, but, you know, also the mobilization and exercises of the neck as well. There's a lot of stuff on like the proprioception of the neck that I've seen. Like they have like a flashlight or a laser attached to their head, and they do like certain,
like the target training?
Yeah, like the target training, or like they go through the maze and they're like looking up, down, circles
with the little headlamp.
Yeah, right. All that stuff is like really geared towards that proprioception of the neck. And then there's even some stuff they've looked at, like separating the neck from the body with that, so like they stabilize their head but their torso's moving. So then it's training to stabilize their head while their body's moving.
Or like you like find the target like straight ahead, and then you like turn away, and then you have to like quickly find the target as fast as you can.
Yeah, I got really excited with that one.
Because then like it's really easy obviously to put your head back in to neutral, but where actually is neutral? And
can you find that spot you need to and come back to it, right? Like same thing, like again, like the receiver analogy, right? They're running, they have to look up at the ball. At a certain point, they're probably going to look down real quick, see where they're at, and then try and like, hey, let's find that ball again,
right?
Kind of thing. So
tracking isn't just done with the eyes.
No, for sure. Absolutely. Your head's got to be put in a position so the eyes can do their job. So now the question kind of comes up is how quickly can we even implement vestibular rehab? And, you know, a lot of the older studies looked at that post-concussion syndrome. So they were initiating this around 3-4 weeks after the actual concussive event. But what we're seeing now is you could probably start doing this a little bit sooner. And there was a really good kind of retrospective study that looked at, they started treatment basically within the week of the injury. So they sustained their concussion, and, you know, depending when they were seen, right? Because this was basically in like a clinic kind of thing, not necessarily like in a traditional setting.
Athletic training where everything is done fast.
Yes. But they basically got it started within the week, which was probably about, I think the patients were evaluated 5 days after the event, and then basically initiated treatment on day 8. So like
that's so
3
long.
days. Yeah. But again, it's a clinic, so when you can get in and stuff like that.
Right.
So again, it shows that there is promise that you could probably start this fairly early if they're having those symptoms. And what that study found was for every 1 day increase in time from the injury, it basically pushed the schedule back another, I love this, 1.02 days.
Oh, wow.
To increase that return to play. So basically that calendar just kept kind of like that timetable kept getting pushed back.
Just slightly over 1 day.
Just slightly over. So they lost a day and an afternoon.
No, 1.02. That's like a day and a couple minutes.
Okay, they missed breakfast. A day and breakfast.
No, I don't. Let me do the math.
0.02. I feel like that's got to be breakfast.
There's 1440 minutes in a day, right?
Sure.
Am I doing that math right?
I don't know. I'm not sure. I'm taking your word for it.
60 minutes times 24 hours.
224 hours. No. Yes, you're right. I got that. I'm picking up what you're putting down.
Okay, so 24 hours times 60 minutes is 1440. Yeah, yes. So that was right. 1440 minutes in a day, and 0.02 of that.
Whoa.
Is just under 30 minutes. It's 28.
Okay, that could be breakfast.
Okay.
That could be breakfast, depending.
So let me just tell your athletes that every 1 day that they didn't come for treatment, they lose a day and 30 minutes.
Yeah, a day and breakfast.
Okay.
My athletes will totally know what that means.
then your athlete's going to come back at you saying, well, I don't eat breakfast, so.
Oh, gosh. And then there's this whole discussion on why we don't eat breakfast. Why are we doing this to ourselves? Yep. So essentially, when it comes to vestibular rehab, remember to utilize your physician and kind of get their thoughts. Is this something they're comfortable with? Or is this something that they're comfortable with you doing / are you comfortable doing it? Right?
Yeah, I've had physicians on both spectrums. I've had physicians who are like, oh, yeah, like, just, return them.
Pencil pushes.
Yeah, return them when they're ready. And I've had physicians who are like, no, they need to come do 2 weeks of concussion rehab, and I'm going to return them. You can't return them.
Yeah. Yeah. So it definitely, right, definitely goes off of our physicians, what they're comfortable with us doing, and, and also, do you feel comfortable doing that? Do you feel comfortable, hey, here's what I'm seeing, here's what I can kind of play with and kind of be able to do, and then also know this part's a little out of my scope. I think you need to see a specialist. Right. If anything, I think it is important for us to at least know how vestibular rehab goes, because if they're going to physical therapy for vestibular rehab, right, it would be nice to be able to educate our patients, hey, here's what to expect, here's what they're doing. Or if they're doing it, like if they're doing physical therapy for it, and you can only go to physical therapy like only so many times, whereas we see them every day. Every day. So making sure that they're doing these exercises right, making sure we know what to look for while they're doing the exercises, right? Like if they're like doing their vestibular exercises, which, I mean, there's it deals with a lot of eye movements and stuff, and they're basically going like, oh yeah, every time I do this, I get like super dizzy, like my symptoms go up to a 5. Yeah, that's a problem, right? We're not doing that right. Right. So making sure at least we have that background to at least identify like, hey, you're probably doing this wrong. You should stop. And that kind of ties into know your referral network, right? Make sure you have a referral network to kind of fall back on. Again, if you're not comfortable or familiar with vestibular rehab, make sure someone in that sports medicine team, hey, I have someone that can do this. I have a physical therapist that, is pretty good at stuff like this. They can tie into this and be able to get that outcome we're looking for.
You know what? What we did is we went at one of my previous jobs. We were just going around visiting our team docs.
Yes.
And they had the physical therapy area, like right around the corner. So we went over, and we stayed for like an hour or two with the physical therapist.
Oh, that's cool.
And learned so much about what they do that we don't do as often, or that is out of our scope or just different than what we do. And there was so much that I actually still implement in my practice just from the 1 or 2 hours that we were there. So
I bet.
If you have someone in your network who is able to do vestibular rehab, reach out to them and say, hey, like, can I come by and just like observe my athlete doing this? Or can I come by and, see if they're willing to work with you on that? Because then you can say like, oh, I just want to make sure that, when they're coming back to our facility, that they're doing these correctly, and then I'm able to cue them and like kind of continue that care.
Yeah.
We have a physical therapist who comes and just kind of observes in what we're doing
that's awesome.
now.
That's cool.
And then we are able to also like collaborate there and have continuity of care within that. And then also I still pick his brain. Like today I just asked him about like muscle energy of the neck. And so
ooh, that's cool.
Yeah. So like a lot of times like people are really willing to share their philosophies and what they do and everything. So even if it's not in your wheelhouse right now, and it's like kind of hard to maybe like look up and get the theory of, if you have someone around you that can, I bet you they'd be more than willing.
Oh, 100%.
And it's probably just an email or a call.
And again, it just shows that, that collaboration between professions and the respect that both professions have for each other. Right. What we do, right? Like, I'm glad you brought that up, right? Like they had that clinic that you went to, right? Though that group there sees this all the time, because those are the patients that are coming in.
Well, it's also things that like they were doing like gait analysis, which yes, we like learned in school, but it's not something that we
do every
go
day.
In depth in and do every day. And we don't have the fancy force plate equipments and stuff. So stuff that they were able to see and then work on in rehab is just like the fact that it's very much in their wheelhouse.
Absolutely.
And they feel very comfortable with it versus someone who maybe just read it in a book or like learned it enough for a test.
Yeah. And that's why, and again, it's vice versa, right? Like, you know, we're comfortable in our environment with, you know, doing an evaluation while we got 5 other student athletes, you know, doing some kind of treatment or rehab, I should say, and like stuff like that, you know, kind of balancing that. And obviously the emergency part, right? Mm-hmm. So we lean on each other for our strengths.
Mm-hmm. You have anything else to add about vestibular rehab?
Nope, that's about it. Action item is vestibular rehab is important when it comes to the concussion process, right? We should definitely be rolling it in, rolling it out. That should be a part of our kind of like multi-tool concussion evaluation and policy. And then if there are any of those, like, hey, this seems like a vestibular issue, you know, you don't have to be afraid to start that therapy for it, right? You know, whether it's maybe you getting them started or, hey, you know what, we need to send you to, you know, someone who is comfortable doing this and letting them go through starting that process. You can start it pretty early.
How many references would you say you used for this?
About 14, 15.
That's pretty good.
Yeah.
So if you're interested in those, we'll have those up on our website, and we have a Facebook group that you guys can head over to, which will, if I remember, I'm trying to remember, I'm going to write down right now. We're going to put the VOMS in the Facebook group, the VOMS little poster thing that I was talking about. And then you guys can collaborate and talk about what you do for vestibular rehab or what you would like to learn about vestibular rehab. And again, if you are interested in the CEUs, scroll down to the show notes. We do have a link for Mass General Brigham CEUs. I think that's what the link says.
Yes.
And if you're good on CEUs this year, or if you're just looking for more on-demand stuff, we do still work with MedBridge. For $150 off, you can use code ATCorner at checkout. And then lastly, we do every other episode as education or stories. This one was an education episode. Next week is stories. I believe it is cranial nerves. So make sure you head to our Instagram at ATCorner Podcast so then you can submit your stories for cranial nerves and so that we can get just other people's experiences with diminished cranial nerves or how they remember cranial nerves and kind of all that.
Yes, that might turn into a not safe for work edition with the mnemonics that are out there for cranial nerves.
Who knows?
But I do have to say that's fitting after we talked about some concussion stuff. A little cranial nerve work.
It is.
I like it.
So anyway, got anything else, Randy?
Nope, that was perfect. Thank you for helping us showcase athletic training behind the tape. Bye.